Good morning. I'm very happy to be here representing UCL. I'm going to be talking to you about the latest developments in diagnosis, treatment, and some of the work that I'm doing as part of my PhD. The three main topics that I'm going to focus is diagnostics, and then I'm going to present to you some data on the PROMIS trial. We're going to talk about treatment, more specifically photodynamic therapy, and then some of the future work that we're doing in biomarkers and imaging. Now, this question comes to me quite often when I speak to patients and when I speak to scientists about prostate cancer. When you say the word cancer, immediately you think it's the end of the world, but also we need to find the cancer as early as possible so we can treat it and get rid of it. Now, with prostate cancer, this is true, but it's also not true because sometimes we have someone with Gleason 6 disease that we can easily follow up doing active surveillance. And that's very difficult to explain to patients because you tell them, look, you have cancer, but we're not going to do anything. So it's very important that when we speak to our patients, we explain why we are not treating this cancer. And sometimes it's difficult to find a nice analogy of why prostate cancer is so unique. And I found this one, and I really like it, so I'm going to share it with you. Imagine you have built an enclosure. You have a small fence, and you need to keep 3 animals inside the fence. The first one is a turtle, and you're pretty sure that the turtle is going to stay inside. There's a small chance it's going to dig a hole and go outside, but it will most likely stay inside that enclosure you built. The second animal is a rabbit. The rabbit may jump over the fence, or it may stay in the fence, but you need to keep an eye on the rabbit, because you don't know what it's going to do. And the last one is the bird. You know the bird is going to leave eventually, unless you build a very good fence, but the bird is going to leave. You may be wondering, why am I talking about animals when we're talking about prostate cancer? Well, the analogy, the turtle is Gleason 6 disease. So we know that the turtle is going to stay there. And I want to make emphasis in accurate diagnosis. So when we say Gleason 6 that stays within the prostate, I mean accurately diagnose Gleason 6 disease, that we are completely sure this is Gleason 6 and that there is no Gleason 4 lurking behind. The rabbit is the Gleason 7. So when we have pattern 4, we know that this is more aggressive cancer. There is a chance that it's going to leave the prostate, but it may also stay inside. And we are working a lot in finding out if there is a subtype on these Gleason 7 patients that we need to pay more attention to, because we still don't know too much about this Gleason 7 pattern. The last one is the Gleason 8 and above. That's the bird. So if you have Gleason more than 8, the chances of it leaving the prostate are quite high. So we are more aggressive with these kind of cancers. Now, the first question when we treat prostate cancer, and I think it's becoming more and more important, is what is our modern, legitimate, clinically meaningful therapeutic target? In other words, what are we treating when we treat men with prostate cancer? In prostate cancer treatment, we have learned a lot from breast. So many years ago, if a woman had breast cancer, you had to be very aggressive, take the whole breast out and clear all the lymph nodes. But we've learned that if you have localized breast cancer, you can take the lump out and observe the patient. This is obviously not as easy in prostate, but we are trying to learn from what the breast surgeons have done to extrapolate this to prostate cancer. So the old-fashioned way of treating prostate cancer is to take the whole prostate out or treat the whole prostate with radiotherapy or hormone therapy. Some of the work that Prof. Emberton and Prof. Hashim Ahmed at UCL have been doing has been in focal therapy. This is an emerging therapy. We're still learning from it, so it's still not common clinical practice, and there are lots of pros and cons with this kind of treatment. And if you look at this prostate, you can see that this man has a large Gleason 6 disease on one side, and there are small satellite lesion. And we wonder, do we need to treat that tiny area of cancer? Can we leave it alone, or do we have to do something about that? And I was talking the other day with a consultant urologist, and he was telling me that perhaps all the research that we're doing at UCL will take my job away. I like to operate, but if we are successful, maybe one day I won't have to operate. So if the past quarter century brought us minimally invasive procedures, then maybe the next will bring elimination of invasion. But I think more than that is treating the right patients and offering the right treatment for the right patient. So the first thing we need to address is, how do we diagnose prostate cancer? At the moment, a man goes to their GP after a certain age, they have a PSA, and then they have their prostate examined. If any of these two are abnormal, they're referred to a urologist to have a most likely transrectal prostate biopsy. And I'm going to talk about all of this pathway, where the faults are, and how we can improve this pathway, or the work we're doing to improve it. Each one of these is a man. I don't expect you to be able to read that, but I just want to show you what 1,000 men look like. This is 1,000 men who've had PSA done as a screening test. Now, of these 1,000 men, 100 to 120 will have a false positive test. You know PSA can be raised if you have an infection, if you have a big prostate. So these 100 to 120 patients will have a biopsy of their prostate with all the side effects that it brings, risk of infection, bleeding, the pain. Of these 1,000 men, 110 will be told you actually do have prostate cancer. And at least 50 will have treatment complications that will affect their quality of life, including erectile dysfunction, urinary dysfunction, plus all the psychological effects. 4 to 5 men will die from prostate cancer. And by screening 1,000 men, you will avoid 0 to 1 death. And I am not saying at all that that one person that we're saving from screening 1,000 men is not important. But what I'm saying is there has to be a better way. There has to be a better biomarker, a better test to save more lives. The second problem with the current diagnostic pathway is prostate biopsy. We do normally, in most places, transrectal biopsy. And here you have a nice schematic representation of what we do. These two are normally not taken, but I like this graph because it shows a big prostate with all these pins inside, and that's how we take the samples. And you can imagine, if you have a big prostate and you put random needles, the chances of finding accurately the disease, they're not very, very good. So we need to target areas. And again, think of breast. If a woman has a lump, you won't see the breast surgeon sticking 12 needles in the breast randomly. They are going to go and target the area that's abnormal. And here is where MRI starts taking a bit of strength, because it can help us pick up false negatives. So this gentleman had a negative trust biopsy, and then you can see here on the MRI, there's a lesion here, and there's a lesion there. This is a different view. And that was not picked up by the trust biopsy. It's not the person who did the biopsy, it's not their fault. Simply, sometimes it's not easy when you're taking 12 samples in a big prostate. But the other thing that MRI does, it can avoid false positives. So this gentleman had a PSA of 5, which is raised for his age. If you look here, you can see the hip bone. And the prostate is larger than that. This is a very big prostate. So imagine again, you go here, you put 12 needles randomly. If this man did have prostate cancer, it was very slim, the chances of finding it. But this man had an entirely normal MRI. So in this kind of patient, we can avoid biopsy altogether. So first of all, I'd like to talk to you about the PROMIS trial, what we did and what we found. This was led by Professor Mark Emberton and Professor Hashim Ahmed. It was sponsored by University College London, managed by the MRC Clinical Trials Unit, and funded by the UK NIHR. This was a national effort. These are all the centers that recruited patients, did all the tests, and this is very important because at UCH we have state-of-the-art facilities, we have very, very good MRI, very good pathologists and radiologists, and we want to make sure that a test can be used nationally. And this shows that you can do a good MRI all over the country. Here you have the recruitment graph. So it started in September 2013 all the way to October 2015. The yellow squares are the target of patients, and you can see that the target was met fairly easily. And then in red, you have the patients that withdrew. There were 3 main objectives to this trial. To assess the ability of multiparametric MRI before a first biopsy, First of all, to avoid unnecessary biopsy, and that's very important. Remember those men who have biopsies but don't need it and still have all the side effects. We want to reduce overdiagnosis of insignificant cancer and improve the detection of significant cancer. And I'll talk about what's significant and what's not significant. And you may find, if you go and have a read, that this definition is a bit blurred. So we are working in making it more specific so that everyone works on the same definition. A patient would be eligible, consented, they would be registered, have an MRI, and it was a 1.5 Tesla MRI. They would then have a combined biopsy. So they would have the normal, the transrectal biopsy, and they would have a transperineal biopsy, and I'll go a bit more into detail in a second. And then the patients will have the results. This study was completely blinded to the operator. So the person who was taking the biopsy did not know the results of the MRI, and the patient did not know them until the end of the study. This is important because you don't want to bias this study. If you know there's a lesion on the right, then you're going to be more careful there. First test, or the standard test that we were testing against, was TRUST biopsy. So there were 12 systematic cores complying with international guidance, and each core was potted and reported separately. The test we wanted to use as our index test was MRI, so we wanted to compare that test against TRUST biopsy. Used a 1.5 Tesla with no endorectal coil. There was an independent quality assurance and quality control of the scans. It was complying with international guidance. So when we say multiparametric, we would take these 4 parameters. And the radiologists would score them using a scale called Likert scale. This goes from 1 to 5. So if the radiologist says that the score is 1, that means that they're quite sure that there is no significant cancer. It's highly unlikely to be cancer. If they give it a score of 5, it is highly likely to be cancer. And then right in the middle is that gray area that we always have in medicine, where you're not really sure if it's one or the other. And any MRI score more than 3 would be considered positive. The reference test was template prostate mapping. This test is very good. So you do a transperineal sampling, and you take samples every 5 millimeters of the prostate. It's almost like taking the prostate out needle by needle. And you can be quite sure that you're sampling the prostate correctly and all of it. So it can be quite a lot of biopsies. The problem with this test, doing it is that you need a general anesthetic, you need a lot of theater time because it can be quite time consuming. But also you do pick up a lot of insignificant cancer, and that's precisely what we want to avoid. But this was a very good reference test because we knew we were going to pick up all the cancer that MRI could have missed or TRUST could have missed. Now, our definition of clinically significant cancer was any Gleason, dominant Gleason 4, so Gleason 4 plus 3 or above, and or cancer core length more than 6 millimeters. So when you take the needle sample, the pathologist would measure how much of the biopsy was cancer. And that gives us an idea on how big the tumor is. So if you have a Gleason 3 plus 3, so Gleason 6 that we don't think is significant, but you have a lot of it, then that is significant and we need to do something about that. So we had 740 men registered. For different reasons, the different men withdrew before the MRI. Then 723 had their MRI completed. 601 had the biopsies attempted, and 580 had all 3 tests completed, with 576 having everything completed according to protocol. The reasons for withdrawal, the biggest reason was a large prostate. When you're doing the transperineal biopsy, I want you to remember that graph I showed you with the red dots. If the prostate's too big and it doesn't fit the grid, then you cannot sample the lateral areas or the top. So we couldn't use those patients for a reference test. So those patients had to be taken out, and that happened mostly before biopsy or during the procedure, in a total of 69. And there were other reasons, men who had advanced disease or they didn't want to take part in the trial anymore. Now, for any cancer, In the transperineal biopsy, 71% of men had any cancer. This is significant and not significant. Most of men had Gleason 6 and Gleason 7. But when you look at the clinical significance, so men with Gleason more than 4+3 or big tumors, that number drops to 40%. So 40% of all the cohort had significant cancer. These men here with Gleason 3+3 and Gleason 3+4, they had large tumors, so we considered them significant. Now, I want you to remember 3 or 4 slides from the presentation, and this is one of them. This is looking at how TRUS biopsy did compare to transperineal biopsy. So you have transperineal biopsy here and TRUS biopsy, and we're comparing how many cancers, especially significant cancers, did the TRUS biopsy pick up compared to our index test. And that gave us a sensitivity of 48%. Now, if I were to consent any of these patients, if these 500 patients, and tell them, I'm going to do a test, and I know that you have cancer in your prostate, and I have a 48% chance of finding that cancer, I don't think anyone would say, yes, doctor, go ahead. So the sensitivity is not great. It's like tossing a coin. The negative predictive value is 74%. Now, when you look at the multiparametric MRI, the numbers are striking. The sensitivity rises to 93%. That means we are picking up the significant cancer more compared, so almost twice compared to transrectal biopsy. And the negative predictive value rises to 89. That means we're not picking the people who don't have cancer. Now, remember I talked to you about Likert scores from 1 to 5. 1, we think there's no cancer. 5, we do think there is cancer. There were 16 men that MRI did not pick up that did have significant cancer. And I'll talk about them in a little bit. But in the Likert scores 4s and 5s, it did pick up all the men that had significant cancer. And that is extremely important. When we compare men who had a TRUS biopsy and had significant cancer missed to men who had an MRI and had significant cancer missed, you can see in the Gleason 3+4, MRI missed 16 men, whereas TRUS missed 99 men. On the Gleason 4+3, so it's more pattern 4 than 3, TRUS biopsy missed 13 patients, whereas MRI didn't miss any patients. And we think that radiologists and the reading of MRI, we are better able to look at pattern 4. There are some changes in the MRI, in the way the cells are packed and how the contrast moves, that the radiologist can almost tell us there is some pattern 4 there. These 17 patients that were missed on MRI are going to undergo deep sequencing. We're going to do a deep genetic analysis to see and then correlate with the MRI to see if we can find any clues on why MRI missed them. And I think it's important to notice that MRI is not the answer to everything because it will miss some patients. But what it does mean is that we need to find some other way, some other diagnostic test, perhaps a blood test or a urine test, that can tell us, look, even though this man has negative MRI, there could be something there. Now, the PROMIS trial has an important potential impact on the diagnostic pathway, and this is the second slide I'd like you to remember. If you take all the men in the PROMIS trial who had an MRI, they would all have had either a TRUS biopsy or an MRI triage. In the TRUS biopsy area, they would all have their biopsy, so 100% would have a TRUS biopsy. When they had the MRI, that would drop to 73% because all the rest of men would have low Likert scores, so we would say, you know, your prostate looks fine, we're not going to biopsy you. You would reduce the overdiagnosis of insignificant cancer from 16 to 11%, and you would detect significant cancer correctly in 37% versus 19% in the men with TRUS biopsy. And what this means is that if you use an MRI scan before biopsy to diagnose prostate cancer, you can help more than a quarter of men to avoid unnecessary biopsy and therefore avoid all the side effects. But even more important than this, we're not picking up insignificant cancer, so we are lowering the stress of men that are walking around with Gleason 6 disease in active surveillance, worried because they have cancer. And I go back again to accurate diagnosis to be sure that they do have Gleason 6 disease and there's no pattern 4 hidden. Now, some of the work we do again is with MRI, and this is what we do to target the area, and this is based on the model of breast cancer. So you want to target the abnormal area, the nodule. So what we do is you take the MRI and you contour the prostate, you contour the lesion. You do this with the radiologist, or experienced urologists can do that themselves. And what this gives us is a 3D image of where the tumor is in respect to the prostate. This can then be extrapolated to the ultrasound image. So you have your ultrasound image there. There are lots of systems that do this. And this helps us because then you can target the area and you can see where your needle is going when you do the ultrasound. And this is the view that we get when we do a transperineal biopsy. So you can see the tumor is there, you put the needle through there, and you have a more accurate diagnosis of prostate cancer. Now, the second topic I want to talk to you about is treatment, and I'm going to briefly talk to you about a trial on photodynamic therapy that was presented here at EAU, and it was recently published. And we go back again to the legitimate, clinically meaningful therapeutic target. So again, we ask ourselves, do we take the whole prostate in a man like this, or do we treat the index, the larger lesion, or do we treat the small lesion? And the work that's been led by UCL on all these focal therapy treatments is to treat the area where we're more concerned about and leaving the rest of the prostate alone. This is all research, so this is not yet clinical practice, but it's worth investigating to see if we can actually control cancer like this. Now, photodynamic therapy is basically injecting medication, photosensitizer, that concentrates in the tumor. You then activate it by light. So in the case of this study, they would have an intravenous injection, and then they would have, just like in a transperineal biopsy, we have a laser inserted, targeted to the tumor. So this was planned with an MRI. And then you would turn the laser on, and what the medication does, it closes the blood vessels, so the tumor has no food and it dies. This was a phase 3 trial, so we had a phase 1, a phase 2 that was done in Europe and Canada and the United States. And I'm going to focus on the PCM301 that was done in Europe. It was an international effort, and it was randomized to active surveillance versus the treatment. So these were men with low-grade cancer. This is a man who had the treatment, so you have the prostate here, and then all this dark area is basically a cavity where the prostate cancer was treated with the treatment, and then there's just a cavity that the tumor is gone. The primary endpoints at 24 months were cancer progression, so this man would have 2 biopsies and their follow-up, compare the men with active surveillance and the treatment. So we were looking at if there was an upgrade in the Gleason grade and the absence of cancer. And the secondary endpoints was crossover to radical therapy for different reasons, the safety of the medication, and also how this medication was affecting the quality of life and the functional status of the patients. This is the other graph I want you to remember. So you have here in blue the men who had the treatment, and then in the orange you have the men in active surveillance. The subjects who progressed in the medication area were 28% compared to 58% in active surveillance. That means when they had a follow-up biopsy, their Gleason grade was higher and perhaps they needed treatment. But that number was quite reduced in the men who had the treatment, and that dropped from 29% to 6% in the men that were treated. The negative biopsy was higher in the men who had the treatment, was 49%. Versus 14%, so TUCAT, this treatment, increased the probability of a negative biopsy and follow-up. And this is the other graph that I want you to remember. We are looking at the functional status of these patients. On this side you have the erectile function, and on this side you have the urinary function. Now, if you imagine a man who has active surveillance, you would expect their sexual function and urinary function to remain the same because you're not actively doing anything to them. When you do the treatment, there is, of course, a decrease in the sexual function, but this goes almost to baseline at the end, which means that if you are going to have a treatment for your prostate, you would like it to have the least side effects as possible, and it's comparable to almost having nothing, which is extremely good. With regards to urine function, there was again a slight decrease in the urinary function after the treatment. but this was actually slightly improved after the treatment. And the explanation for this could be if you have killed part of the prostate, it's like you're doing a procedure to open up the prostate so the men could pass urine better. With regards to adverse events, because remember one of the things that we're looking at was the safety, about 81 men in the TUCAT group had moderate side effects. And in the active surveillance that came about 52, so 41 to 25%, but these were moderate, these were not severe side effects. And then it's comparable in the other grades, 3, 4, and 5, between the two groups. And there was one man who had anaphylactic shock, so that's to keep in mind, but it is a safe medication. So the conclusions from this study is that this medication appears to be desirable to European men, is safe, is well tolerated, is amenable to quality control, and is effective at reducing rates of progression. It can confer negative biopsy status and diminish the need for radical therapy. And I want to stress that this is all research, and these are technologies we're learning from, so these are very nice results, but we still need more data, we still need to do more research before this becomes clinical practice. And last but not least, in the 3 minutes I have left, I want to talk to you about the work we've been doing and I'm going to be doing as part of my PhD in liquid biomarkers and imaging. This is one of the trials we're working on in our lab, the Whitaker lab. It's called INNOVATE. And when I was telling you about MRI and those patients that we missed with cancer, we're trying to find a group of biomarkers. And a biomarker is any substance that can be raised or low in the body that can help us see how a disease is progressing. So PSA is a biomarker. So we're trying to find new biomarkers that we can measure in blood and urine to see if we can predict negative MRIs. So this is the standard pathway. Now someone has a DRE and a PSA, they have a TRUS biopsy, and then if that biopsy is negative, then they may be offered an MRI in the future. The way we do things at UCH, we have someone with an abnormal DRE, a raised PSA, they have an MRI, and then you have two options. There is no lesion, we do nothing, we monitor the PSA, and then a targeted biopsy if there is a lesion. The new proposed pathway is that if you have a suspicion of prostate cancer, you would do the novel urine or blood biomarkers. If they are negative, then you reassure the patient, you tell them the risk of you having prostate cancer is quite low, you don't need an MRI. If they are positive, then they would have an MRI, and then there's this sequence called VERDICT, which we are researching, and then they would have targeted biopsy or surveillance depending on the results. This is a color-coded image of how the MRI looks. So you have the original here, and then you can see that the lesion is shining, and this is combining all of the parameters that VERDICT is looking. So this is being developed by some very smart people in UCL, physicists and radiologists. It takes about half an hour extra. The patient has to stay in the MRI, but then it can give us a very good delimitation of the lesion. Again, research, so we need to see if this actually works before we take it to clinical practice. The outcomes are to assess if this VERDICT MRI improves the accuracy of multiparametric MRI to see if it can help us find that significant cancer we're missing, at least by a minimum of 10%. And the secondary outcome is to look at a group of fluid biomarkers to see if it can help us predict men with negative MRI, so to avoid the cost of doing an MRI. That's all I have to say. This is all the research team. Thank you very much.